this is the fourth Advanced Pediatric Endocrine Symposium, which we are organizing. The first one in the form was actually started off in 2017. And since then, many of the faculty, all the guiders, everybody is the same. And we are continuing with the same team for quite a long time. It's been really a pleasure in that regards. Now, when we had initially, we were always thinking that pediatric endocrinology is a rare group of disorders, which are complicated, which are cumbersome in terms of workup and very expensive treatment. So people used to, in a way, shrug away from pediatric endocrinology, don't want to go into this field, and everybody was very scared, so to speak, about that. Now, when we thought about this, what we realized that there are three issues in any health problem: awareness, accessibility, and affordability. Now, everybody says these are not affordable, but we believe that awareness actually is the elephant in the house. And if we increase the awareness amongst the general public, amongst the physicians, we would be able to improvise the care. And this was the motto by which we established the pediatric endocrine group, and then we started the Growth Society working in that direction. Now, if you look at the pediatric endocrinology burden in India and the specialists who are available, what we see is that we would probably have a handful, maybe 100 will be the overall, maybe an overestimation also at the moment, but now with more fellows, the numbers will increase. So this still is a very, very small number for the burden of population for type 1 diabetes, growth hormone, thyroid, all those things. And pediatricians are approximately in much bigger numbers. So we need to really have a bridge in which things can improvise and connect between the two so that we can have a continual good quality care in everywhere. So currently pediatric endocrinology is focused and centered in few cities. Some cities like Bangalore will have maybe 20 people who are there, but then some whole states will not have people who are trained at all. So we need to have more wider exposure, and that's why it's very important on part of everybody. And it's responsibility of us pediatric endocrinologists, and ISPE has been working a lot in that to really spread the message of pediatric endocrinology. We have been doing a lot of programs right from 2011, and you can see many of the same people have been involved, and they have always been our inspirational force there. We started with our first program in 2011, and then since then there have been hundreds of programs which were done in terms of workshops, in terms of advanced courses, practical courses across the country, which we have been conducting. Now, this basically is the third Advanced Pediatric Endocrinology Symposium. And from there, what we realize that if we keep on doing workshops, how much time can we spend? Like, it's not possible to do workshop everywhere. So we started off with social media in terms of YouTube platforms. And from there, a large number of people actually were able to access, and you don't need to be there all the time. They can access that. Then we started an on-site fellowship program, and we have got Chetan from the first batch, Neha from the second batch today, who are there. We until now had 11 fellows who are being under part of training. Then what we realized is that if you want to have a structured training, we need to have a web-based program. So we started with our MedEClasses platform, which provides a lot of information, started with books, and then to practically use that knowledge, mobile applications were developed. So we have got a lot of e-learning videos available on YouTube with huge number of views. This is something which is available covering entirety of pediatric endocrinology. We have got structured learning program under our learning.growsociety.in. We also offer a 2-year hybrid program for fellowship and a 1-year hybrid for diploma. We had got a lot of people who come to us every 6 months for a week. They learn the exam. So it's a very intense process. So we are going to have some of the announcements about the results of the fellowship program, the first one. We conduct a lot of online courses, pretty much 3 to 4 every month. So it's quite intense. We have got a number of publications which are there. And what we are going to launch today is the second edition of our pediatric endocrinology protocols, which is a completely updated book about latest protocols for pediatricians, pediatric endocrinologists, and we'll be releasing this today. One major advantage we wanted to take was with regards to our application, because that will provide much easy access to use, because what you learn, if you don't use it immediately, you will forget and the errors will come in. And these applications were developed, and they are now become the most popular endocrinology application across the globe. And we have done a lot of publications regarding the growth interpreter, which allows practical interpretation of growth. We have got the obesity interpreter, which has been validated. We have got puberty interpreter, which allows interpretation of puberty, for thyroid, for DSD, and all of them have been presented and they are in publication in different places in that regards. Now, what we have done now is a very interesting thing, which is actually a combination of all that we have done. This is a bone age assisted interpretation of growth. So all the pediatrician would have to do is to put some basic data. It includes information like birth weight, sitting height. So all the rough things that we anyway write down and we measure, we just write the Tanner staging, we match it, we have the bone age interpretation. And as soon as this is done, it is using all the algorithms which are available. And based upon this algorithm, we will have a lot of information, data points will be available. So you will have specific charts, bone age interpretation, lot of parameters, and this will predict the likely diagnosis, most likely investigation. And we are validating this now. So this will be a very valuable tool for screening pediatric endocrine disorders. And hopefully, so this is how the result will look like. So you will have charts and you will have table which has got a lot of interpretation, and then we'll give you the final interpretation as to what is the likely diagnosis in that regards. We are coming up also with a personalized intelligent EMR, which is going to basically decide based upon specific conditions, give the inputs for every condition. And once you choose those conditions, you get the data, you will get an output which will guide in terms of evaluation, assessment. So only those which are relevant will come up on that drop-down menu. And based upon that, you will have a state-of-the-art evidence-based algorithm-driven approach which will come and analysis will come. This will provide information in the form of also a nutrition chart. So a 7-day meal plan will be there. So we had got, recently we had this on-site course in which we had got large number of people who had come from across the country, and we had around 200 patients who were seen over the last 3 days. And we had a very intense discussion which was there. So this Advanced Pediatric Endocrine Symposium, we're going to cover a lot of aspects of pediatric endocrinology. We'll talk about two basic topics, monogenic diabetes and hyperinsulinism. So monogenic diabetes is a very, very important part of diabetes. As we discussed, maybe 2 to 5% will have it, but then you will have huge implications in terms of diagnosis, treatment, and other aspects which are relevant. And you need understanding of this very importantly. This graph, I've already told this table. So individuals with MODY will typically be ones which are lean, with strong family history, 3 generations which are being involved. And typically they will have up onset usually after puberty. That's a typical thing we'll discuss, but we'll also show cases who may deviate from this phenomena. So MODY basically would be the ones who are 10 to 25 years of age, who have autosomal dominant inheritance, 3 generations involved, and they have rarer acanthosis and ketosis. And these parameters will be important. And again, GAD antibody is pivotal. So don't light off type 1 diabetes just because the requirement is less. So when do you evaluate for genetic causes? In apparent type 1 diabetes, if you have reduced or no insulin need and detectable C-peptide beyond 1 year of diabetes. And if you have a strong family history and antibodies negative. In what you think of type 2 diabetes, if they don't have any obesity or acanthosis, you think, this is the graph that we already shown regards. So if you have an onset before 6 months of age, think of neonatal diabetes. After 6 months of age, you have a lean individual with no insulin requirement, negative GAD antibody. Think of monogenic diabetes. The monogenic diabetes could be insulin deficiency or insulin resistance. The most common form is glucokinase defect, which is basically a defect in glucose sensing. So they will have mild fasting hyperglycemia. Then the levels don't go up. The more important ones are HNF1 alpha and 4 alpha, which will have a more persistent hyperglycemia, and they will respond to sulfonylurea. You also need to think of renal anomalies, especially in HNF1 beta, which becomes relevant, and insulin resistance like scenario acanthosis, which will happen with lipodystrophy-like syndromes. So we'll start off with the cases, Dr. Dhwani. Yeah.
The first case, we have a 15 days old baby girl with failure to thrive, had a low birth weight of 1800 grams, and at 15 days has a even less weight of 1600 grams. She's sick looking, has a blood glucose of 425 milligram per deciliter, no ketosis, but and appears dehydrated.
So the important thing to, am I audible?
Yes.
Yeah, looking at this basic data, this is a IUGR or a preterm, whatever.
So, yeah,
So So 1600 grams, the baby has lost weight, sick looking, and is ketone negative. So this is hyperglycemia, because for all in the audience, I'm sure that 0.6 and below is ketone negative. So 0.2 nanomole is, so there is a neonatal diabetes out here. So that's the impression looking at this.
So management-wise?
The management-wise is, as Anurag had mentioned and the earlier speakers, is don't waste time. Insulin, small doses. You can give basal bolus. You can give small doses of short-acting insulin. But yes, rehydrate and give insulin.
So beyond this, what is the important investigation-wise? How will you go forward in this case?
See, basic thing is you have to understand that this is in the neonatal age group. And I think the most important resounding message for the evening is it is now very clear-cut, not only in the 2022 ISPAD guidelines, but even the earlier ADA criteria. Below 6 months, if you have onset of diabetes mellitus, first and foremost, consider some genetic cause. And I think this should resound because, way back 10 years ago, I had a baby with neonatal diabetes. And in those days, we didn't have access to genetic tests, which we now clearly have. And there are many, many resources available. So there we continue to treat with insulin. And very interestingly, the baby outgrew the insulin. And I think, let's see what happens with this case.
So this child was again could not afford to get a genetic test done and improved over time.
That's right. So improved over time means with time, the insulin requirement went away. And so everybody was happy, especially the parents and mostly the relief doctor. The chalo bala to haath se nikal gaya. But in reality, this today, in today's day and age, we know differently. And this is called transient diabetes mellitus. Anytime it disappears between 1 month and 18 months, it's called TNDM, with the caveat that they can again relapse up till 18 months of age. And worse still, it can come back and hound Dr. Rishi Shukla if he's still here, an adult diabetologist, much later.
Yes, so at follow-up at 12 years of age, this child had polyuria, high blood sugars, and an HbA1c of 8.4%.
And so what happens, and just to very quickly just enunciate what Dr. Anurag so elegantly spoke in the 20 minutes of rapid fire type 2 diabetes, is for some reason, monogenic diabetes does not strike the mind of the adult endocrinologist, diabetologist, and sometimes us as well. So it is very important to ask that history in every patient, even with garden variety type 2 diabetes. Was there any sugar problems in infancy? And I
In
think
fact, this child came to us with the second presentation, and then we took the history. Okay, he had some diabetes. So this is what the point.
This is a very important point, that if you have a child coming to you in the adolescence, as Dr. Anurag had so well said, is that's the point, a cusp point where we really have to look at all the options. But yes, was started on insulin. We did the genetic test. And mind you, genetic test in a child who doesn't fit the Modi profile, 3-generation, lean, non-obese, and all that. It's because there was a past history of transient neonatal diabetes mellitus. And it changes life. With sulfonylurea, off with insulin, in with the drug.
So I think very good message that genetic analysis is mandatory for neonatal diabetes in this day and age. Maybe 10 years ago, it was not available. Early onset neonatal diabetes may be transient, as we discussed, and it recurs, as Dr. Subrato said, and responds to sulfonylurea in that case.
Moving on to the next case. So now we have a 2-month-old boy, later presentation as compared to the previous case, with failure to thrive, had a near normal birth weight, and now at 2 months is only 2,800 grams, has hepatomegaly, myopathy, and neurological weakness, very high blood sugar, HbA1c of 9.9, and hypertriglyceridemia. So Dr. Ahila ma'am.
I think it's working.
Yeah.
So the presentation and the discussion, I think Subrata and Anurag and Dhwani have already finished everything. So it's typical again, it's a 2-month-old boy. So as already mentioned by Subrata, it has to be worked up for neonatal diabetes. The main, probably the point which would help you towards focusing on some particular diagnosis, myopathy and weakness, which actually comes with some forms of neonatal diabetes. And they may be associated with hepatomegaly too. But that weakness is something which really triggers, what do you say, a red flag in your mind to watch out for something. Because the most important point is early pickup of these patients and giving appropriate treatment can save them from neurological sequelae in early life, in later life. Because delay in diagnosis can definitely harm them in the long run. So they've already started, as mentioned by again Subrata, that basal bolus with small quantities of bolusing with a short-acting insulin, and then a targeted panel and a KCNJ11 defect. Because of the myopathy and weakness, yes, it is probably a DEN syndrome. And this DEN syndrome, it's very difficult to predict the long-term sequelae. Even yesterday, I had my patient with DEN. You're not sure whether it was the diabetes which harmed their neurology or the mutations that are manifested in the neurons in the CNS, which actually led to the long-term sequelae. But yes, there are a lot of thoughts on whether early start of sulfonylurea could have saved these children much and had a better life.
I think that's a very, very important point, that it's not just the glycemic control, it's the potassium channels in the neurons. And if you not activate at the right time, you will have a problem. So that's the very important. So people say, okay, we cannot afford, we'll continue insulin. You're not only missing on giving sulfonylurea, you're missing on this neurological outcome, which becomes very, very important, very, very valid point. So again, we are talking it many times. We are looking like a brand ambassadors for maybe some of these genetic testing groups, but definitely every child should have a genetic analysis. It's freely available also through the Madras Diabetes Research Foundation, who do this for free. And late onset, as we saw, could be permanent, and genetic testing will give you a clue in that regards.
12-month-old girl with failure to thrive had a birth weight of 2,500 grams, had RVS of 360 and normal ketones, no ketosis, family history of consanguinity, and this is the X-ray that we see. I would like to pose this question to Dr. Riddhi.
And I think this was the case Riddhi had seen here only.
So this is the little bit later presentation at 1 year of the age, and child presented with significant failure to thrive. Sugar was high, there was no ketosis, and history of the consanguinity. So that suggests some familial forms of the diabetes, and the X-ray suggestive of small phalanges. So there is some problem in the skeletal development. So this can be a skeletal dysplasia. And yes, so X-ray suggestive of small phalanges. So whenever the diabetes associated with some skeletal problem, skeletal dysplasia, especially spondyloepiphyseal skeletal dysplasia. So a Wolcott relation syndrome comes first in our mind because it is frequently associated with the skeletal dysplasia. And also there was this Wolcott relation syndrome is caused by this EIF2AK3 gene, and this is homozygous defect. So you may find history of the consanguinity in the family.
It's in fact the most common diabetes in consanguineous family. But we do see a lot, and often people used to say that this is a fatal disease. They will have liver dysfunction and they will die by 1 month. We have seen so many cases, 5 years, 6 years, 12 years, who are surviving. And there have been reports from Dr. Vaman as well. I think you were also mentioning about the report. Yes, please.
Just a point, I think I'm not sure. I welcome all of you to the APES meeting. And Dr. Mohan was and his team was talking about the neonatal diabetes and the monogenic diabetes. They said Wolcott rallison is quite common in India, and they said that was a third common mutation that they were seeing. So I thought that was quite interesting because it's supposed to be very, very rare. But
and we always heard that it was fatal when we read it earlier in the textbook, but now we are seeing cases who are like pretty good. They're doing reasonably well. They have got a lot of digit abnormalities, and I think fingers become very, very important. I think Riddhi had seen this girl who had come to us.
Right. What are the skeletal dysplastic features in these children which you have seen?
So there was some epiphyseal
Predominantly small phalanges which were there. There was like a acrodysostosis like picture which was looking out, like resorption of digits. That's what was there.
But there was no significant skeletal.
Yeah. And the hepatic
they were also short.
Short, but not hugely short. Not like a proper
a short trunk is
no, predominantly the fingers we found in this case. And mostly couple of cases I've seen is this sort of phenotype. So if you have any skeletal abnormalities, always think of this. I think that's the message from the general audience we would like to give probably. So
Because
Wolcott,
genetics of Wolcott relation is like the misfolded protein accumulates and then causes beta cell apoptosis. So onset can be delayed as long as 3 to 4 years. So literature is.
so it's more like a double hit model. So if you have a later onset quote unquote neonatal diabetes, think of two conditions, insulin defect and Wolcott-Rallison. These are all later onset presentations. They are not like, they're like star defect, which presents a bit later than CAH. Same thing happens. It's a double hit hypothesis. So anybody in the consanguinity, if you have a family history, skeletal dysplasia, monitor for SGPT. Often it's maybe bad, but we didn't find any problems in these cases.
2-month-old boy with failure to thrive, high blood sugar, history of skin infection and diarrhea. I would like to, and had GAD65 positive.
So why did you do a GAD positive GAD antibody at 2 months?
So again, less than 6 months, we think of
Genetic
Yeah, I
causes,
think
but
he has given the clue. So basically, this is a.
so is it type 1, Dr. Subbu?
No, that is the interesting thing, that all that is GAD positive is not type 1. But having said that, not the garden variety type 1. Let me put it that way. Yes, GAD positive means there is an immunity problem. It immediately doesn't transfer to garden variety type 1. Now, I like Anurag's these bullet presentations because they give you all the nuggets, which I will encourage the doctors in training to be looking for. So he has looked at skin infections or dermatitis or eczema, and he has looked at diarrhea, which is an enteropathy. And then he has asked for the GAD65 because it is a pattern recognition. Out of the blue, a 2-month-old will not get GAD65 done. This is the message, that ultimately it's all clinical and not algorithmic. It's not that you take a protocol or a guideline and go down. It is still cognitive. You have to see, and that's where your clinical acumen. So you have a 2-month-old failure to thrive, diabetic with some skin infection, dermatitis, with diarrhea, which is enteropathy. Some red flag is running in your mind. Next slide, please.
So this is the immune defect.
That's right. So this is your APEX, which is immunoregulatory defect with polyendocrinopathy, with enteropathy and X-linked. So it's only seen in boys. And the important thing is that if you recognize it, you'll be looking for other polyendocrinopathies like the thyroid disorder, and then they have the eczema and thrombocytopenia. So it's a pan disease, and the type 1 diabetes needs insulin.
And Riddhi presented very well that they need a very aggressive course. It's a bad prognosis disease, of course, and they will ideally need a hematopoietic stem cell transplantation. It's a difficult one. Do not give them immunization. So it's a challenging disease. It will require a proper workup in that. So early onset immune diabetes, it's actually the earliest immune endocrinopathy. We say MEN1, MEN2. This is the first one to come out. Multi-system involvement. Think of a progressive, which may be a fatal disease also in that regard.
16-year-old girl with increased urine output underwent screening investigation, which showed RBS of 258 and HbA1c of 8%. Ketones 0.8, so just the mild ketosis. Now BMI is 16, and that is she is underweight and has no acanthosis. She was labeled as type 1 diabetes. Started on insulin therapy. She developed recurrent episodes of hypoglycemia.
So Dr. Rishi is not there. Riddhi will take over this case, I think.
So this patient, 16-year-old girl, and typical presentation of DK, initially managed well with the insulin and started with the insulin, but on insulin therapy, she had recurrent hypoglycemia.
And even off therapy for more than a year.
Okay.
So, and we got a C-peptide done also, which is detectable. So,
But I have a question. The ketone of 0.8 means there was ketonuria. Do they have ketonuria?
So this
There
was
was
not
mild
really
ketosis.
DK. It was like ketotic diabetes. It was managed on probably on an outpatient basis.
So it was ketotic.
It was ketotic, mild ketosis.
Mild
basically.
ketosis.
Mild ketosis. which is indicated by the HbA1c also. So this is the flags. These are pointers that you said that when you don't have that high HbA1c, you don't have ketosis, it can still be type 1, but start thinking, okay, this is something else also going on in that perspective. So Riddhi, now what will you think of?
So
in this
typical presentation like type 1 diabetes, but the markers are lean individual, no ketosis, requirement of insulin is very, very low. So suggest some monogenic form of diabetes, and also GED was done, that was negative, that also points this can be monogenic defect. And the genetic testing was done, suggestive of HNF alpha defect, and that responds well to sulfonylurea.
Was any family history?
Yes, there was a family history which was
Because
noted.
that is one thing I would put there.
Yes, yeah.
is
So
a
that was
family
there.
history.
We deliberately didn't put it in that regard. So often we don't take that much details, but later on he had a sprank family history on that. So HNF1 alpha defect, clearly I discussed, is a defect in which you have got a transcription factor MODI. So your fasting levels will be high. Post meal may not be very high. It's a progressive disease. They respond very well to the management with sulfonylurea, as Riddhi has already mentioned. So sulfonylurea at a very low dose. You can also use a GLP-1
This is the
receptor analog.
opposite, where the fasting is okay.
That will come. That will come.
No, there.
That case will come, I think.
No,
GCK.
that case is where the fasting is high, the
GCK.
postprandial is normal.
Yeah. So I
Itna
think,
hota hai.
yeah. So GCK, I think we might have skipped it out. So the second type, MODI, type 2, which was the next case, I think we have removed that case, is when your fasting is slightly high, but your post meal becomes normal because your glucose sensing is defective. So body is not able to recognize till a particular level, after which says, okay, come down. So this is opposite of glucokinase deficiency, which is a mild diabetes, does not require usual.
But MODI 3 is the commonest.
MODI, yeah, these one will be the
MODI
most
3
common.
is the
Yes,
commonest
yes.
MODI.
The commonest MODI is GCK. It is not picked up.
No, MODI 3 is
No,
still
no,
the commonest.
No, no. If you look at the prevalence study, if you actually study genetically, it will be the most common, but nobody diagnoses them because nobody gets their sugars checked. This is the most commonly identified form of, which is absolutely right. That's what you're saying, is the most commonly identified form of diabetes. But the actual, if you ask, GCK deficiency is absolutely common in the community. 5% GDM patients were found to have actually GCK deficiency.
So you remove the GCK case.
I think I will see.
No, then it's very important to talk about GCK to say it is very much present. And then you pick up GCK because some alert subspecialist sends the patient to you saying that the sugar is a little awry, the fasting is high, but the PP is normal.
Yes.
What do you make out of it? So there again, gene study, and you get the diagnosis. And she's walking around scot-free without medication. But with the caveat, when you get pregnant, better come back, you might need insulin.
Yes, that is a very important message. So HNF and 1 alpha MODI is lean, low insulin requirement, 3-generation family, do a targeted panel, low dose sulfonylurea.
We have a 15-year-old girl with osmotic symptoms, has a high fasting sugar of 220. 2-hour postprandial is again 380 milligram per deciliter. Has an HbA1c of 10.4, presents with DK and has started on insulin. She is, however, lean, has no acanthosis and family history of diabetes and mother. Has fluctuating sugars on insulin, had to be stopped from insulin therapy.
She takes 1 unit of insulin, her sugars will go down and then high. So it's like a mess. And this has been now there for 1.5 to 2 years. So
Yeah, that's a typical red flag for watching out for MODI or monogenic diabetes. Whenever beyond 1.5 to 2 years, you are still on less than 0.7 to 1 unit per kilogram per day, then you're looking at some other diabetes other than type 1. And then lean and does not have any other features of type 2 either. But there is a strong family history of the mother also having diabetes.
and
Again,
I think grandmother also had that because she came in the on-site course. I think that this curve came. Yeah.
But there's one point, nowadays I'm convinced you don't need the 3-generation
Yes.
because this identical case I have just diagnosed in a 14-year-old boy who have been treating as type 1. He takes 1 unit and he gets hypoglycemia.
And you may have de novo mutations. So of course you can have a de novo mutation. So this concept was when the genetic testing was not easily available. Now I think when you have a doubt, we took very good criteria in which if you have tracking, you should get it done because it will change a lot of factors and we'll see how it changes here. So what we found, she had multiple renal cysts and mother also gave a history of multiple renal anomalies. So this was a very, very interesting case of HNF1 beta. So we have now the HNF 1 alpha, 1 beta. So how do you go in terms of further management, Dr. Ahila, from here?
Again, for any diabetes, when you diagnose, you always start an insulin, but when you have this fluctuation,
Definitely. So if we compare the three most common forms which we are discussing, one of course is HNF 1 alpha, that you will manage very well with sulfonylurea. HNF 1 beta, you would need insulin here or there later. And GCK is the best except for pregnancy. That was a very, very important point. If you have a mother who has diabetes, but the child is also affected, no problem. But if the mother is affected and child is not affected, that will be a problem. Then the child will develop macrosomia. So in that scenario, you monitor the child's weight. And if you see a baby who is developing features of overgrowth or something, fetal overgrowth, then you treat with insulin in the mother. Otherwise, glucokinase deficiency is a benign condition, doesn't require treatment.
But this condition, have you actually encountered?
This is the case. We saw this case in the on-site.
You did, no?
Yeah. So this is the same ultrasound we showed. So insulin resistance, temporary role, and it will be lost usually. Insulin will be required ultimately. So HNF 1 beta is fluctuating, renal cyst, progressive disease, insulin requirement is there.
We have an 11-year-old girl diagnosed case of type 1 diabetes at 8 years of age. Requires insulin about 1 unit per kg per day, has visual complaints, and was taken to an ophthalmologist who gave diagnosis of retinopathy. So I would like to ask this question to
So Dr.
Riddhi
Riddhi, so she developed such early retinopathy.
She's the girl diagnosed at 8 years of age, and within 3 years, she developed retinopathy. And this is falsely interpreted as this is the diabetic complication, early diabetic complication. But she was on only 1 unit per kg per day of insulin. Requirement was less. Even
And her control was also good.
diabetes.
Control was good.
So on controlled diabetes, we don't expect retinopathy very early. So in this case, we have to think of the genetic cause, especially WFS1, that is the Wolfram syndrome, which presents with diabetes, followed by optic atrophy, and followed by the diabetes insipidus.
So if you have a very early onset, first decade involvement of non-immune diabetes and eye symptom, that is the most common constellation for DID mode. Now, DI may develop later on. Optic atrophy will develop earlier. Deafness may develop. Dr. Bifina will be presenting a very interesting case tomorrow in which she actually had deafness also and DI also. So generally we say second decade, third decade, but you may have all, it's a genetic condition. It may present whatever. You can't say that you will have to do this to present. Dr. Ahila.
yeah, I've had quite a few of these Wolfram because I have a huge patient with diabetes and retinopathy he refers. They're all progressive. The long term.
It's a very bad, it's a bad
because of the
disease.
neurological outcomes.
Yes.
They gradually evolve and not a very good long.
So it's a bad disease. I would say two bad diseases are APEX and definitely this. Wolcott-Rallison, don't be too worried about. It's not that bad in that regards.
The only thing about Wolfram is the one which we have been following is this kid is kind of chugging along, presented with diabetes, then developed DI and some, eye impairment, which was actually a mild optic, optic nerve involvement. But he's lost to follow-up because he's 18. But till 18, he was coming, ever now and then. Why do you say that they're...
So they have a very bad renal and a cerebellar outcome. Death is usually by 30 years. So it's a bad. So it's like third decade, generally they have bad prognosis. So it's not a good disease to have. Neurodegenerative disorder. It's basically a endoplasmic reticulum stress disorder. So anywhere you have got those endoplasmic reticulum, gradually it will keep on hurting. And that would be the scenario.
We have an 11-year-old girl.
So if you have a non-immune diabetes of early onset with optic atrophy, deafness and DI may be late manifestations. Okay, so we have this case.
11-year-old girl on routine investigation was found to have a higher fasting blood sugar and a normal postprandial blood sugar. She was lean, had no acanthosis, had an HbA1c of 6.4 and non-ketotic. She was started on insulin because of the high HbA1c and developed hypoglycemia.
So this was actually referred from an adult, as you said, and they thought to start insulin, sugar is high, fasting is high, but developed hypoglycemia. So Dr. Rishi is not there. Dr. Subrata, this is your favorite case. Then we
Yes,
are
I think this is still there here.
Yes, yes,
It's
there.
normal. I mean, normal in the sense, as Anurag had pointed out, very important, that 100 to 126 is impaired glucose tolerance. And this is impaired glucose tolerance, but this is not, diagnostic of diabetes. And neither is the postprandial diagnostic of diabetes. And is not even in the impaired glucose tolerance.
So
you
this
do
is
the
a classical presentation of
Of GCK.
GCK defect.
Yes.
So you will have very little rise. So opposite of HNF 1 alpha, 3 4 alpha, where you have high fasting and PP will be, fasting will be not very high, but the delta will be very high. Here the delta will be very less than 40 is generally what is recommended. So this is classically a glucokinase MODY. It's basically a condition in which you don't need to treat. Usually we already discussed this about that. And manifestations of fasting glucose, limited prandial rise, and HbA1c will remain stable throughout that. The only indication for treatment is if you have mother who is pregnant and the baby is not affected. So then you will behave like IDM. So in that case, you will have to control.
And the other caveat is,
Yeah.
which I faced in this child, is you must write in block letters, because if they need surgery, if
Yes.
they need some, immediately people do a fasting blood sugar and they will say is a diabetic. You better get a clearance. So you write there, this patient is fit for surgery.
Yes, I think this is a very interesting case.
Moving on, we have a 12-year-old boy with polyuria, history of developmental delay, hyperphagia, infantile hypertonia, fasting sugars of 140, 2-hour postprandial of 220. And this is the clinical image of this child.
This is for Dr. Subrata.
What do people think about this boy? Yes. This is a classic Prader-Willi. And the only thing is the diabetes part is unfortunate, but it does happen. And it is very difficult to treat because it increases their appetite and they eat like crazy. And guess what? The drugs we had were only metformin. And I had a patient I followed for 6 years. He doesn't like metformin, has loose stools, hates insulin. And guess what? At that time, GLP-1 analog wasn't there. So if there is one medication we want to give this kid, is a metformin, GLP-1 analog, and SGLT2 inhibitor. Because
And in fact, there are studies on Prader-Willi without type 2 diabetes also, where GLP-1 receptor analog has been tried. And the newer one, the semaglutide in an injectable form, has been used in Prader-Willi.
correct. And semaglutide has now been since December 22.
Obesity.
For obesity, it has been passed by the FDA, where you give an injection once a week. But
Yeah,
it is
unfortunately, that's a problem that we don't have that injectable semaglutide. We have got the oral one, but maybe we can try that by the
But
time.
apparently, the oral one
Is not big enough.
Yeah, it's not big enough. You have to give a high dose, 2.4.
Yeah. No,
No.
not yet. We prefer weekly dulaglutide, as Dr. Subrata said. So I think this is a very challenging case. Diabetes is just one part of the story. He will have huge number of problems. Sleep apnea. He was there, in fact, in the ICU. He was ventilated. I think Manoj was there at that time. Probably Vibha was also there. So it's a very, very stormy course.
And if you give me just 1 minute,
Yeah.
in fact, this I want to share, not because of anything else. is as pediatric endocrinologists, we have a huge role in not only diagnosing these things, but motivating the family. Because last year, 2 days before Diwali, I lost a 12-year-old who weighed 120 kilos, who had everything, had sleep apnea, type 2 diabetes, had hypertension, and pulmonary hemorrhage. And this child, unfortunately, came to my orbit with about 6-8 months before, made him lose weight. He was in BiPAP all the time, even during daytime, but he started walking without oxygen. From that stage, the parents, they felt they can manage it all because they have been managing it for the last 7-8 years without seeking any medical assistance. And so then I get a call 3 days before Diwali, lost to follow up for 6 months, that he's not waking up, he's unresponsive. He was a diabetic too. So I did the blood sugar karo, 285. Then I said, "Ab bahut jaldi daud ke, you go to our ER." I alerted my team was ready. It was a DOA, death on arrival. So Prader-Willi, you have to actually nurse them. And on the other side, the son of the current Prader-Willi president, she's from Bengal. I don't want to name her name for confidentiality. Her son is only 82 kilos and is 6 foot 2 inches tall. So, which makes me feel that I should probably repeat the fish test or what. But anyway, so it can be done with motivation.
So I think this is a very, very challenging condition. Of course, much things have to be done in that regards.
17-year-old girl with hirsutism had an FGS score of 21, amenorrhea, severe acanthosis, but a BMI of 16. So she was a lean phenotype, had high fasting and postprandial blood sugars, and ultrasound showed large ovary with a PCO appearance.
So she was one of the most severe PCOS that you will see, but she was lean. But when you looked at the neck, she had very, very severe acanthosis and developed diabetes. So Dr. Ahila, I think you take over.
It's a lipodystrophy syndrome because she's lean, though she's a lean PCOS, like because of the large ovary, the PCO appearance, particularly the Ferryman-Galway scoring of 21, amenorrhea, and as he mentioned, the severe acanthosis in the neck. And if you look at the hands, it's a very, very important clue. They have slender, long, and you can see the veins stand out. You have absent fat. They look like a muscular, but actually a weak muscular person. And that's a very typical clinical feature of lipodystrophy syndrome. So you have a spectrum, a hair AN syndrome,
yes,
hyperandrogenism, insulin resistance, acanthosis nigricans, which can become more severe into the other forms of lipodystrophy. They're very, very difficult to treat. It's quite heartrending to see the girls go through this, but they do ultimately well, but we don't get, all the drugs are not available in India, but they are on high dose insulin.
And many times they develop virilization very severe, and that becomes a problem because this hypertrichosis will cause testosterone in 200, 300 milligram per DL. You'll have clitoromegaly. It's like a mess, alopecia. I've seen all sorts of problems. So this is a bad condition again. Very high dose metformin. I had given GnRH analog and aldactone. Everything was given, but it's a difficult one.
Yeah, I've seen the whole spectrum of all the lipodystrophy. Don't know you, Raps and Mendenhall. This one had the worst forms of Barnard-Lee syndrome.
So we'll now quickly move towards the hyperinsulinism part. So we should think of hyperinsulinism if you have persistent hypoglycemia, which is non-ketotic, and your reducing substance is negative, and you have a detectable insulin. So essentially, detectable insulin in a child who has got no ketones, think of hyperinsulinism. And very importantly, hyperinsulinism has got a sensitivity of only 82%. So in 18%, you may have a zero insulin also. So this is also important. You have to be aware of that. C-peptide is maybe a better marker. So people talk about C-peptide, but ketone is a very good marker. If you have hypoketosis, it's got 100% sensitivity and specificity. Some people tend to look at glucagon response as well. You give glucagon, and everybody who is hypoglycemic should not respond to glucagon unless they have hyperinsulinism, because it's an antidote to insulin. And low IGA-BP, these are rarer scenarios. So anybody who has a high GI,
But this is vis-a-vis what venous plasma.
This is basically in terms of in the presence of hypoglycemia.
Right. So 30, 40.
Yeah, so it will be like below 50. Yeah, yeah.
That is the definition.
Hmm.
Having said that, this one caveat there, which I've seen over the years,
Hmm.
is if you take at what happens is when you take at, when the glucometer shows a number, usually in the lower levels, the glucometer is not that
Yes.
accurate. So you'll get a number like 40. But when you send a plasma venous glucose, it comes back at 50, you know.
So this is actually from one of the big studies which had come from UK,
Yeah.
which looked into the sensitivity specificity. So the message is C-peptide is also a very helpful test because it has got a longer half-life, and insulin we discussed in the morning will be very labile. So often insulin, how it is carried also becomes important.
Right.
C-peptide is a robust test to look at. So increased insulin effect can be because of increased insulin levels. We're largely talking about congenital forms, which can usually I'll be focusing on monogenic forms largely, and very rarely you can have increased insulin action. So we'll focus mainly on the monogenic forms of hyperinsulinism and one scenario of prolonged hyperinsulinism. So how do we approach? If you diagnose hyperinsulinism, you give them dextrose, start diazoxide right away. Diazoxide is easily available. Start from 5 to 10, go up to 15. Within 5 days, their sugar should become normal. If they are responding, then your job is very much done very well. You may do basically in the form of giving, getting ammonia level, which will diagnose you GDH. Otherwise, you continue diazoxide. Problem happens. A genetic study, or specifically looking for the potassium ATP channel. So genetic study with potassium ATP channel, both for the father and the mother. So if you have basically a recessive defect, if you get the mutation in both these cases, in that case, clearly it is mostly a diffuse disease. So a homozygous K-ATP channel defect is basically extensive disease, will require surgery. It's a very, very difficult scenario. However, if you have a paternal defect, heterozygous defect coming from the father, this could be a focal disease. And in that setting, you can do a PET and you can avoid surgery. Now, this is easier said than done. Many cases, you will not get a diagnosis. We have a child whom we are going on. Our CT was normal. Our every genetic study was normal, but he's responding to diazoxide. But then we realize that his 1 month cost is 20,000, is requiring so much diazoxide. So it's not an easy disease. Here we have said, okay, diazoxide continue, but how long to continue and for a poor family will be an issue. So main approach, however, is start diazoxide, response good, no response, genetics, and then imaging. That's what we will say in that perspective. So
I have one caveat to that, because in real terms, how a baby actually comes to us. They have a baby in the nursery or in an ICU who is hypoglycemic. Now, who among all of you are neonatologists? Anybody here? Because the message for any neonatologist or general pediatrician is refer these hypoglycemic patients to a pediatric endocrinologist soon, rather than at the age of 7 days, 10 days, when you are at your wit's end. So one real-time scenario I want to just inject for just 30 seconds is if you have a IUGR baby who is not being able to keep the sugars up, who is non-septic, these babies, oftentimes when you do a critical sample, you will find low sugar and high insulin, 2, 3, 4, whatever. And these babies respond wonderfully to that.
So this is the case. This is the case.
This is the case.
This case which we are presenting is the same one.
Okay.
So you're somehow predicting our cases.
No, the important message why, no, this is vis-a-vis what in the general algorithm you say.
Yes, yeah.
So you start them on diazoxide. If they respond, jolly well. But then they are not scrawny, they're actually a little macrosomic, maybe infant of a diabetic mother, maybe a Beckwith-Whiteman, or maybe just a genetic baby. There you give diazoxide, and then you move to octreotide. And you stay on octreotide because I have one such baby who's on octreotide even now, diagnosed as diffuse disease by genetics as well as by DOPA screening. But the treatment still remains.
So are you giving the long-acting one?
You know what? I have zero experience with the long-acting one.
Okay.
And so if you have,
It's a good one, actually. It's a
yes,
good one.
I will take your thing, but the child has been lost to follow for the last 3 months, but they have been taking the injections.
So this is exactly the case which Dr. Subrato said. We wanted to show that everything is not genetics. So you have to think of other things as well. Yes.
This 14-year-old boy had birth asphyxia, admitted in ICU, had low blood sugar despite being on GIR, having high GIR requirement. Ketone was negative, insulin was detectable in presence of hypoglycemia, had a birth weight of 1.6 kgs. So I would
Dr.
like
Ahila.
Already discussed.
So Dr. Subrato has already discussed that this is prolonged hyperinsulinism basically. This is because of the hypoxia inducible factor, because they were in perinatal stress and the body has accustomed to this state, and that's why they're producing more insulin, which may be a safety mechanism. You can.
I just have some few points to add, not only pertaining to this. So gallium hexandin actually
Yeah.
gives much better results for scanning of the hyperinsulinism. As you already mentioned, spending so much money, even long-acting octreotide is also quite expensive. And we don't get too many patients at the same time to share the cost.
Yeah.
And the dose also seems to be just sufficient for one child. So in the long run, for some families who can't afford, we still offer pancreatectomy because we just want to save the child. And even in focal disease, I have not been very successful with just focal surgery. We have had to convert it into near total pancreatectomy again.
So it's again, so if you respond very well to low dose, if you have this form, you are happy. Otherwise, life is not very simple. That's what the message would be.
And just one point, one single episode of hypoglycemia can damage the brain forever. That is why, as Dr. Subrata said, don't wait too long. Any neonatologist, you have significant hypoglycemia, refer immediately to preserve the brain.
And the length of stay, preserve the finances.
So prolonged hyperinsulinism, basically in birth asphyxia, SGA, no macrosomia, of course, and stress severe hypoglycemia, which lasts to 6 to 8 weeks. This is the best outcome you will see basically.
3-year-old boy with severe hypoglycemia had a birth weight of 4.6 kgs, high GIR requirement, and a negative ketone. Insulin was detectable in the presence of hypoglycemia. So, Riddhi ma'am, if you could take
So
up
this is the typical case of hyperinsulinism, detectable insulin at the time of hypoglycemia and non-ketotic. As sir has discussed, we have to give diazoxide trial, and diazoxide was started at a dose of
10 mg.
10 mg per kg per day, and then it was increased to the 15 mg per kg per day, but still there was hypoglycemia, and the baby was not responding to the higher dose of diazoxide also. So we started with the glucagon infusion, and genetics was sent suggestive of potassium ATP channel defect. Homozygous form of potassium ATP channel defect. So this was a diffuse disease, require the surgery anyway.
So in these sort of cases, what is your experience with long-acting octreotide? With
Some of them respond quite well.
What do you use?
somatostatin, the one, the Sun Pharma. Yeah, 20,000 to.
So we calculate, I go up to 40 micrograms per kg per day, total cumulative dose for a month, and then give it. And one of my So one of my patients actually has been on long-acting octreotide now for almost more than 2.5 years on a monthly dose, totally well, doing extremely well. So I just take the cumulative dose, and they just come for an annual follow-up because they're
When you transition, how do you transition?
once the child settles with the short-acting octreotide and are able to maintain their blood glucose, then I convert it into a long-acting.
No, then you just abruptly stop the short acting and give the long acting,
No, I put the long-acting and then gradually wean off the short-acting.
because the dose may vary depending on each.
No, how
different
much
patient.
of dose have you given through the day till you achieved euglycemia, and then I calculate that as a wholesome
30
dose for the,
days.
for 30 days and then put it. And it's usually quite high. It goes up to even 40. I just had a question for you. So how many of you start diuretics when you start diazoxide?
Not true till we skipped that slide. So
Oh,
I do,
basically,
but, you know,
I
yeah.
do.
So
Yeah.
I would
I
do
do.
usually after 3-4 days, we find fluid retention,
Okay.
and we'll start with thiazide. One message: never start furosemide, because furosemide will potentiate the effect of diazoxide. You will have decay. I had seen a case which was referred in Australia a long time ago with a similar thing. Somebody gave furosemide and developed decay. But yes, I agree that thiazide will be helpful also in other forms as well because of the potassium effect as well.
Now, just for 1 second, this is mainly a debate really. what you said, you start low, then build up. Now, in our cost-cutting scenario, what I found is you start high and rapidly you reduce it over next 3-4 days. You can come down to 5 mg per kg per day, and then maybe just send them on that and stop it after a week.
So yeah, so protocols definitely. So we started around 10. You will start probably at 15 or
15.
something.
I started
That's
15.
fine. But very importantly, think of cardiac overload. Maybe many times we get an echo done. There are a lot of other issues.
Yes.
Renal dysfunction may happen. So you have to be careful.
That is
Dioxide
very
not a
important.
safe.
You must get an echo done before, because they can get a cardiac
Open.
overload.
Yes, exactly. And you will have platelets. So there, it's not an absolutely safe drug, but it's the drug which is very good. It's easily available now. And Jolly Pharma is available. So I think that's a good thing which has happened from that regard. So this case again is a very severe form. And if you have this case, you would need a pancreatectomy most likely.
18 years old boy with hypoglycemia at a birth weight of 3.4 kg, high GIR requirement, and ketone of 1.2 millimoles. Insulin was again detectable in the presence of hypoglycemia. So, Subrata sir, maybe you could take this case.
So it's slightly different from the last one, not much different, I think. The weight is lesser
And ketosis.
and the ketosis is there mild. So it's a bit different from the last one. So again, you will start with diazoxide. I think that's what we have discussed. And what we
But
found.
why is there why is there ketosis?
So if sometimes if your insulin is not very high, you may develop, you may go up to 1.6. That's why they've used the criteria of till 1.6, you may have ketosis. And if you use less than 1.6, you have 100% sensitivity, 100% specificity. So on follow-up on diazoxide at 10, there was no improvement. Hypoglycemia was there. But on analysis, we got the pattern. So this was a second case.
Okay, so this
This
is
is
the
more like a
focal
focal.
disease.
So it's a milder disease.
It's a
basically.
focal disease.
Yes. So, this,
So on a focal disease, I must say this, that just a caveat to the previous case. So we gave octreotide, the sugars didn't stay up. And then we had to do on site, we did a near total pancreatectomy. And that baby went home and is now lost to follow up because the sugars are totally fine. Maybe we'll come back with diabetes later. But I had a focal disease presenting at 6 months of age, and that baby's lesion was so close to the head that the pediatric surgeon said, I'm not going to operate on the head. So focal disease itself doesn't mean that you can operate and come away.
Yes.
There are some nuances there.
Yes,
But I think the message here is it's a heterozygous and you have done the Sangers on both the parents, isn't it?
yes.
You're sending all three.
Yes.
That is the important thing.
So rapid genetics, that is the recommendation. Now, how often you will be able to do it is different, but ideally you should do for all three. So if it's a heterozygous from the mother, doesn't matter. Heterozygous from the father is what you will have this focal disease, because this is like a 2-hit model again. That's what we have written, 2-hit. So we have not gone into theory specifically in this one because it's all available, all the
So
resources.
what we did was on that focal, we did the scan first and the genetics later.
Okay. Yeah. So if you have access to the
But-
scan and
But to no avail, patient went lost to follow.
so early onset, normalish birth weight may have a paternally inherited KATP defect. Focal surgery may be effective in this scenario.
21 days old girl with hypoglycemia, birth weight of 3.2 kgs, high GIR requirement, had ketone, again negative ketone, and insulin detectable in the presence of
So
hypoglycemia.
Riddhi, you will take this one.
Hyperinsulinism, and she was also given a diazoxide trial.
And she
Start-
had a very good improvement in
Improvement.
diabetes.
GIR was reduced down. Ammonia was on the higher side. That suggests that may suggest the HIHA syndrome, that is the hyperinsulinism, hyperammonemia syndrome. And this found to be GDA defect that responds well to
So I
diazoxide.
think this is a quick clue that if you're responding to diabetes, get ammonia, it will be like 100, 120, not too high. You know it's a defect which will continue on diazoxide, low dose will continue on this.
But again,
this-
sir, cost become very.
I know it's a long-term treatment is very difficult, but what do you do? Like you have to, otherwise option would be to remove the whole because they don't have a focal lesion. So again, this is a late onset normal birth weight, diazoxide response, high ammonia, which will be there in that scenario.
The diazoxide gets rid of the ammonia, is it?
No. Ammonia is a different mechanism altogether. It does not affect anything. It is not, it's just a marker that GDH is not working, is activating mutation of the GDH. But your ammonia is not doing any harm. So you don't treat that ammonia.
GDH meaning?
Glutamate dehydrogenase. So this is the activity in which the activity is increased. So your internal ATP levels increases. So we've got three defects: GCK activating mutation. You've got the SCAT, which is the fat pathway, and this is coming through the protein pathway. This was known as the leucine sensitive hypoglycemia. So in which your protein dependent ATP production is more. So if you take more of a high protein diet, you will develop hypoglycemia more in this case.
HADH mutations causing hyperinsulinism. I've had
Yes.
two patients.
Yeah.
So if you take non-veg, they typically land up with hypoglycemia. And that mother was very specific. The day she takes fish, she's gone hypoglycemia.
So earlier they used to say leucine sensitive,
Yeah.
protein
Actually,
sensitive.
she grow out, as they grow older, some of them grow out of it.
Many of these disorders, like even these things, these are milder defects. So later on, you may be able to eat so much, you don't develop hypoglycemia.
A 12-day-old boy with lethargy was found to have hypoglycemia, no ketosis, insulin was detectable during low glucose, and had a birth weight of 4.2 kgs, had umbilical hernia and ear crease. Ahila ma'am?
Typical your ear crease and met with Weidman syndrome, the birth weight, everything. I have one boy, only thing we are just watching for future complications because they are at higher risk for malignancies in later life. But otherwise, the child is doing quite well.
So generally, it's a transient hypoglycemia, diazoxide responsive, and often they will behave like a prolonged hyperinsulinism.